Hi, welcome back. So let's start with a question. A 55-year-old man with long history of chronic obstructive pulmonary disease presents with increased shortness of breath, so difficulty breathing. Arterial blood gas on room air was done and it showed pH of 7.35, which is slightly decreased. PaCO₂, which is partial pressure of carbon dioxide, of 55, which is increased. PaO₂, which is partial pressure of oxygen, that's decreased, right? Less than 60. Bicarbonate in this patient is 30, which is increased. And the oxygen saturation of 87%, which is decreased. His hemoglobin is 16 and his cardiac output is normal. Which of the following best describes this type of hypoxia that's present in this? So looking through this option, the best answer here will be hypoxemia, leading to hypoxia. So let's see why. So, there's no way we can talk about hypoxia without talking about oxygen delivery to the tissue. And before we talk about look through oxygen delivery to the tissue, let's look at how the oxygen gets from outside the body, in other words, from the atmosphere, and it gets into the level of the tissue. So as we know that oxygen or gases move based on pressure gradient. So they move from where there is high pressure to where there is low pressure. So starting from the atmosphere, so this barometric pressure, which is atmospheric pressure, right? This is going to drive the oxygen into the airway. So it's going to be our airway. And of course, in the airway, we have to humidify the air, right? And then once we humidify the air, then that's going to be, so our oxygen will be PiO₂, right? So PiO₂ is the partial pressure of oxygen in the inspired gas. And then how are we going to be able to, so the formula for this will be, right? Like we said, we humidify the air. So that will be your P atmosphere, right? Because that humidification will further decrease the oxygen tension. So that will be P atmosphere minus partial pressure of water. And then you're going to multiply this by what? By your FiO₂, which is the fraction of oxygen in the inspired gas. And as we know, right, this is usually 21%. So if you're on room air, this is going to be 21% normally. And then from there, this PaO₂ then is going to drive the oxygen into the airway. Into the alveolar. So next is going to be the alveolar. And in the alveolar, so that's going to be P capital AO₂, right? Which is partial pressure of oxygen in the alveolar. And if you remember the last gas, right, after exhalation, when you breathe out, the last gas in the airway is going to be what? Carbon dioxide. And this carbon dioxide will further decrease the oxygen tension in the alveolar. So if you want to calculate the partial pressure of oxygen in the alveolar, so that's going to be, so you have to remove partial pressure of carbon dioxide from this PiO₂. So that means this is going to be, so we already know our PiO₂ to be P atmospheric minus P water, right? Multiplied by FiO₂. And then this, we're going to now subtract the partial pressure of carbon dioxide. And remember, this carbon dioxide is measured in the blood, right? So that means we have to divide by respiratory quotient. And this is what we call alveolar gas equation. And then from here, from the alveolar, right? So the oxygen is going to diffuse into the what? Into the blood, right? Into the capillary. It's going to diffuse into the capillary in exchange for what? CO2. So oxygen comes into the capillary and the CO2 will go back into the what? Alveolar. So this CO2 now is going to dissolve in the plasma. So it's going to dissolve in the plasma. So when it dissolves in the plasma, that will be PaO₂. So small aO2. So it's going to dissolve in the plasma, which is partial pressure of oxygen in the plasma. And then from there, right, it's going to go on the hemoglobin, right? It's going to bind to the hemoglobin, right? And that's going to be our oxygen saturation, right? And so oxygen will bound to the hemoglobin. And then from there, it's going to go to the what? To the level of the tissue. So it's going to go to the tissue, right? So from there, it's going to go to the tissue. And here, somewhere around there, we're going to have our what? Our capillary, right? So, and at the level of the tissue, right? So the oxygen will go into the tissue in exchange for what? In exchange for CO2 that's coming from the tissue, right? And of course, in the tissue, one of the organelles, so your mitochondria, right? So the mitochondria around there is going to use this oxygen. Remember, we spoke about it in the last lecture. It's going to use the oxygen to make what? To make ATP. So going to produce ATP, which is a major source of energy in our body, right? So now those deoxygenated blood, so now remember the oxygen has gone to the tissue in exchange for CO2. So those deoxygenated blood now, they're going to go back into the vein, right? And then from the vein, they're going to return back to the what? They're going to return back to the heart. And then from the right side of the heart, they're going to go back to the lungs for oxygenation. And then the cycle continues again, right? So if you look at what's called so if you understand this, then you can be able to understand things that leads to what? That causes tissue hypoxia, right? So if we go to the next diagram, so what's going to be our oxygen delivery to the tissue? So the oxygen delivery, so when we talk about oxygen delivery, so what determines the oxygen delivery to the tissue? So oxygen delivery is dependent on the pump, right? So your cardiac output, right? So cardiac output multiplied by, right? Oxygen content, right? So multiplied by oxygen content. So arterial oxygen content. And when we talk about the arterial oxygen content, so the arterial oxygen content will be equal to oxygen in the blood. So summation of oxygen that is dissolved in the plasma plus the oxygen that is bound to the hemoglobin. So that will be oxygen in plasma plus the oxygen that is bound to the hemoglobin. So when you add both of them together, then that will give us the oxygen content. And then when you multiply that with cardiac output, then that will tell you about the what? Oxygen delivery to the tissue. And anything that affects any of these variables, right, will lead to what? Will lead to tissue hypoxia. So let's now go through the notes. And then we're going to come back to that diagram in a second. So when we look at oxygen delivery, so this is the amount of oxygen transported to the tissue per minute by the blood, right? And this depends on how much oxygen the blood carries and how much blood the heart pumps, right? So when we look at the formula that we use to for the oxygen delivery, like we said, is going to be the cardiac output multiplied by arterial oxygen content, right? And when we look at our cardiac output, right, if you remember, is stroke volume multiplied by heart rate. And anything that affects the oxygen delivery to the tissue will lead to tissue what? Hypoxia. So let's now look at the arterial oxygen content. So like I mentioned earlier, so the arterial oxygen content will be the combination of both the oxygen in the plasma, right, plus the oxygen on the hemoglobin. So the oxygen on the hemoglobin will be 1.34 multiplied by hemoglobin multiplied by your oxygen saturation, right? And in the plasma will be 0.0031 multiplied by partial pressure of oxygen in the plasma. So where do we get 1.34 from? So each gram of hemoglobin carry about each gram of hemoglobin can carry about 1.34 mils of oxygen, right? And the hemoglobin, right? So hemoglobin will be hemoglobin concentration, right? And the saturation, right? So this reflects how much oxygen bound to the hemoglobin, right? And then we also spoke about the partial pressure of oxygen in the plasma already, right? So when you look at through these variables, so what are the major contributors to the oxygen content? So the major contributors to the arterial oxygen content include the 1.34 that we mentioned, and then most importantly, your hemoglobin. So the hemoglobin is a major determinant of the arterial oxygen content. And you can see with the partial pressure of oxygen in the plasma, this is just a minor what? A minor contribution. So if you look at, so at the end of the day, if you look at, if you extend our formula, like we said, so if you look at the oxygen, the formula for oxygen delivery, right? So formula for oxygen delivery will be our cardiac output, right? Multiplied by oxygen content. And we said that oxygen content will be 1.34 multiplied by hemoglobin multiplied by oxygen saturation, right? Plus, so we're going to add this, right? 0.0031 multiplied by 0.02. So when you so looking at this formula, so anything that affects any of these variables will lead to decreased oxygen delivery, and that could lead to hypoxia. So if somebody have decrease in cardiac output, like any form of shock, right, then that could lead to decreased oxygen to the tissue, and that could lead to what? Hypoxia. If somebody is bleeding, right, somebody who have anemia, right, that could lead to decreased oxygen delivery to the tissue, and that could lead to what? Hypoxia. If somebody have decreased oxygen saturation, right, as we're going to see in a second, that could lead to decreased oxygen to the tissue, and that could lead to hypoxia. If somebody have decrease in partial pressure of oxygen, right, which is what we call hypoxemia, that could lead to decreased oxygen to the tissue, and that could lead to what? Hypoxia. So if we go back to, so let's go back to our diagram, right? So looking through this diagram, so let's look at things that could lead to hypoxia, right? So one will be hypoxemia. So hypoxemia. So if there is decreased partial pressure of oxygen in the plasma, right? So that will lead to hypoxemia, and that will lead to hypoxia, right? And then because if with hypoxemia, then that will lead to decrease in oxygen saturation. So hypoxemia will lead to decrease. So everything downstream will be affected. So that will lead to decrease in oxygen saturation, and that will lead to decrease in oxygen content, right? So your oxygen content will be decreased, and that will lead to decreased oxygen delivery, and that will lead to what? Hypoxia, right? And then the next one is, what about if somebody have anemia? So if somebody have anemia, so with anemia, the problem here is decrease in hemoglobin. So there is decrease hemoglobin. So with anemia, remember everything upstream. So upstream will not be affected. So in this patient, they're going to have normal PaO₂. So there will be normal partial pressure of oxygen in the plasma. Also, saturation will be normal. Hemoglobin saturation is normal because if you only have two hemoglobin, those two hemoglobin are going to be what? Saturated. So your oxygen saturation will be normal. But the oxygen content, right, will be decreased. So there have to be decreased oxygen content, like we mentioned earlier, right? Because if hemoglobin is decreased, that will affect the oxygen content. So there have to be decrease in oxygen content, and there have to be decrease in oxygen delivery. So that could lead to what? Hypoxia, right? Moving on to the next one. What about if somebody have something that is binding to the hemoglobin instead of oxygen? So that would be number 3. So example would be somebody who have what? Carbon monoxide poison. So if somebody have carbon monoxide poison, right? So when you look at when you compare carbon monoxide to oxygen, so the carbon monoxide have more affinity to hemoglobin than oxygen. So because of that, remember everything upstream will not be affected. So with carbon monoxide poison, your partial pressure of oxygen in the plasma will be normal. So there'll be normal PaO₂, so that will be normal, right? Your saturation, so they have to be decreased in oxygen saturation, right? And the way you're going to detect it, right? You may not be able to detect it with pulse oximetry, the regular pulse oximetry, because that only have two wavelengths. So you have to use the Cox oximetry. So you have to use what they call Cox oximetry to be able to detect this. So your saturation will be decreased, and then because the oxygen saturation is decreased, that will lead to decrease in oxygen content, right? That will lead to decreased oxygen delivery, and that will lead to what? Hypoxia. Number 4, what about if somebody is exposed to an oxidizing agent, and that oxidizing agent change the Fe2 plus, right, the ion, right, in the hemoglobin, and change it to Fe3 plus? What's that going to be? Very good. So that will be methemoglobinemia. So with methemoglobinemia, the problem with methemoglobinemia is that it does not bind to oxygen. It cannot carry oxygen. The only thing that is good for, it can bind to cyanide. So that was going to be a story for another day. So with methemoglobinemia, so remember, everything upstream will not be affected. So you're going to have normal PaO₂. So PaO₂ will be normal, right? But the oxygen saturation, so the amount of decreasing oxygen saturation will be decreased, right? And then the oxygen content will be decreased, right? And the oxygen delivery to the tissue will be decreased, and that will lead to what? Hypoxia. Very good. Moving on. What about if the oxygen can get to the tissue, but the tissue cannot use the oxygen, right? Maybe something is inhibiting the mitochondria, or something is causing dysfunction of the mitochondria. So this could be a classic example of what? Cyanide poison. So with cyanide poison, this inhibits complex. So this inhibits complex 4 of the electron transport chain, which is what we call cytochrome C, right? Oxidase. So they are both the same thing. So by inhibiting this complex 4, that means mitochondria will not be able to use that oxygen to be able to make what? ATP. So with somebody who have cyanide poison, so everything upstream will be okay. So that means the partial pressure of oxygen in the artery is going to be normal, right? The oxygen saturation will be normal, but the oxygen content will be normal. Oxygen delivery is going to be normal. But the problem is that the tissue is not using the oxygen. So as a result of that, by the time the blood moves to the venous side, it's still going to have a lot of oxygen in the vein. So that means with cyanide poison, when you look at the mixed venous oxygen, is going to be what? Is going to be high, right? Other things that will also affect the mitochondria. Say somebody is drinking a lot, right? A lot of alcohol, so that will also cause what? Mitochondria dysfunction. So let's look at the let's go through the notes. So what are the so causes of tissue hypoxia? So we spoke about them already. So anemia, right? We spoke about that. Hypoxemia, right? Desaturated hemoglobin, maybe due to methemoglobinemia or carbon monoxide poison. And then note, if there's decrease, anytime you have decrease in oxygen saturation, that could lead to what? Cyanosis, right? And it could also be a circulatory problem, right? Whereby there is normal oxygen in the blood, but there is decrease in tissue perfusion. So, example, somebody who have a heart failure, or somebody who's in shock, right? Or local ischemia, right? So that could lead to tissue hypoxia. And the last one that we mentioned is histotoxic hypoxia, whereby the cell cannot use the oxygen. And the example that we gave is cyanide poison. So moving on, so let's now talk about evidence of tissue hypoxia. So what are the things that we're going to see that could be suggestive that this patient is going through, there is hypoxia going on in this patient? So in the central nervous system, so patient could be restless, they could be confused, they could be having headache, and they could be in coma. Cardiac, they could have tachycardia, arrhythmia, and it could lead to what? Ischemia, right? And in respiratory, they could be having difficulty breathing, like what we saw earlier in that question. They could be hyperventilating, because if you look at the peripheral chemoreceptor, right? What are the things that stimulate your peripheral chemoreceptor? Very good, right? So it is stimulated by increase PCO2, it is stimulated by decrease in PO2, right? And it could be stimulated by changes in what? pH. So changes in CO2, partial pressure of oxygen, and pH, all this could stimulate the peripheral chemoreceptor. And if they are stimulated, so the patient is going to be hyperventilating, right? And in the kidney, right, so they could have release of erythropoietin, because as you know, anytime there is hypoxia will stimulate production of erythropoietin. And where is erythropoietin produced from? It's produced from the interstitial cells of the peritubular capillary. So this is going to lead to increased red blood cell, and that could lead to polycythemia, right? So that's why patient who has chronic hypoxemia, they could develop what? Polycythemia, right? And of course, they could have increased creatine, right, and decreased urine output. And because there's absence of oxygen to the tissue, so the tissue, they're going to be doing anaerobic glycolysis. And we spoke about this the last time, that the fate of the pyruvate, right, instead of being converted to acetylcholine to go into the TCA, so the fate of that pyruvate is going to be shunted to production of what? Lactic acid. And that could lead to metabolic what? Acidosis. And in the GI, right, so they could have nausea, vomiting, bloody diarrhea, or abdominal distension. Liver, they could have elevated AST, ALT, and in the skin, right, if their saturation is decreased, they could have cyanosis, which is bluish skin or mucosal discoloration. So moving on to the next one. So what are the tissue in the body that are more prone to hypoxia, right? So let's go through them. So in the brain, right, so irreversible damage start happening after 3 to 5 minutes of hypoxia. So in the brain, within 3 to 5 minutes, you start seeing irreversible damages. And then remember, in the previous lecture, we spoke about the reversible changes that we see with hypoxia, right? Cellular changes. So in the brain, so areas that are going to be affected, so hippocampus could be affected. So hippocampus is the memory neurons, and it's usually the first to die. So that could lead to memory loss. So that's why patients who have hypoxia, they could have memory loss, right? Cerebellar Purkinje cells, right, which help with coordination, is our coordination neurons. So that could lead to ataxia. Neocortex, right, like layers 3, 5, and 6, right? And the watershed area in the brain. So the watershed area in the brain is the junction between your anterior cerebral artery and middle cerebral artery, or middle cerebral artery and posterior cerebral artery. So those areas are considered watershed area. So if somebody is in shock, or they have hypotension, those areas are going to be affected in the brain. And what about in the heart? So in the heart, the subendocardium of the myocardium, because if you look at the heart, right, so starting from outside, so we have your pericardium, you have your myocardium, which is the muscle, and the inner part is going to be what? Subendocardium. And then when you look at the coronary artery supplying those areas, the area that is far away from the blood supply is the inner part, which is the subendocardial myocardium. So that area is far away from the blood supply. So that's the area that will be very vulnerable to ischemia. And can somebody tell us what's the EKG changes you're going to see if somebody has subendocardium ischemia? Very good. So you're going to see ST depression, right? So ST depression. As opposed to if they have transmural infarction, right? Then they're going to have EKG change. You can see ST elevation, right? And in the heart, so between 20 to 30 minutes of ischemia, so you start seeing irreversible damage, and that could lead to myocardial infarction. So that's always time is money in hypoxia. Moving on to intestine. So in the splenic flexure, is also another watershed area, because in that area, that's when you have limited collateral circulation, and that's the junction between your superior mesenteric artery and inferior mesenteric artery. So that area, there's limited collateral circulation there. and that could also lead to what? That area is also prone to hypoxia. In the kidney, so in the kidney, we have the proximal tubule, so the straight portion of the proximal tubule, and the thick ascending limb, right? And the medullary segment. So, and then in this thick ascending limb, that's where your sodium, potassium, 2-chloride pump are located. So this area are very prone to hypoxia. So this could lead to ischemic necrosis. So it could lead to acute tubular necrosis. And this is important. It's important to remember this, especially for the exam, because if when you look at things that could cause acute tubular necrosis, right, it could be ischemia, right? It could be nephrotoxic, right? If it's ischemia, ischemia will affect the proximal tubule and will also affect the thick ascending limb. But if this is nephrotoxic, right? So if you look at the kidney, right, once those toxins are being filtered into the kidney, which part of the kidney are they going? Which part of the nephron are they going to get to first? Yes, the proximal tubule. So if the cause of this acute tubular necrosis is due to nephrotoxic agents, then the area in the nephron that will be affected most will be the what? Proximal tubule. So that's going to help you to be able to differentiate the etiology of the acute tubular necrosis on the exam. Like we always say, there's always more than one buzzword on the exam. And then moving on to the liver. So in the liver, so when you look at the zone, so you have zone 1, right? You have zone 2, and then we have zone 2 and then zone 3 of the liver, right? And then when you look at in the zone 3, that's where you have your what? Your central vein, right? And remember, the central vein drains into the hepatic vein, and then from hepatic vein that will go into the what? IVC, right? But the hepatic artery is on the other side, right? So the hepatic artery is on the other side, and that takes blood this way. So that means if blood is moving from zone 1 to zone 2 to zone 3, the area that will be far away from the blood supply is going to be what? Zone 3. So zone 3 is far away from the blood supply. So that's why zone 3 is going to be more prone to what? Hypoxia. So zone 3, which is hepatocyte, which is located around the central venous, and the most affected because it's very far away from the blood supply from the hepatic artery. So we've come to the end of today's lecture. So let's look at some questions. Let's do some questions together. So the first question there, a 40-year-old woman with severe uterine bleeding due to fibroids present to the emergency department with fatigue and lightheadedness. So that sounds like symptomatic anemia, right? From a severe uterine bleeding. So we did some vital when she arrived at the emergency department, right? Blood pressure looks okay. Heart rates maybe a little bit on the high side. Respiratory rate looks okay. We did oxygen saturation, which looks fine. But guess what? Hemoglobin is on the low side. So we decided to do a blood gas. So looking at our blood gas, everything looks fine. So what the question is asking us is that which of the following best describe this patient's oxygen delivery to the tissue? And if you remember, what's the formula for the oxygen delivery, guys? So we say oxygen delivery equal cardiac output times oxygen content. And we said that oxygen content will be 1.1 oxygen on the hemoglobin, which is 1.34 multiplied by hemoglobin multiplied by oxygen, our oxygen saturation, right? And then we're going to add this to the one on the in the plasma, and which is going to be 0.003 multiplied by what? PaO₂. So looking at this, which one do we think is affected in this patient, right? I think it's going to be the what? Hemoglobin. So because of the anemia, so that would decrease the oxygen content, that would decrease the oxygen delivery, and that will lead to tissue what? Hypoxia. And it's going to make a lot of sense now why this patient has normal oxygen saturation, because even if they have only 2 hemoglobin, that 2 hemoglobin will be what? Saturated. And they also have normal in PaO₂. So the partial pressure of oxygen in the plasma is also normal, because remember, that's upstream. But guess what? They could develop what? Hypoxia because of decrease in oxygen content. So looking through this option, I think the best answer there will be A, right? Very good. So let's do the last question before before we stop. So a 62-year-old man is brought to the emergency department after being found unconscious at home. Emergency medical service initiates CPR for cardiac arrest, and a spontaneous circulation is restored after 8 minutes, right? Remember, we said that irreversible brain damage after cardiac arrest happen after when? Between 3 to 5 minutes. So it looks like we're a little bit late here, right? Is stabilized and admitted to the intensive care unit. 24 hours later, he remains comatose despite normal vital signs and oxygenation. Which of the following area in the patient's brain is most likely to show irreversible injury to hypoxia? Remember, we said that the first one to go is going to be what? Hippocampus. So I think we've come to the end of today's lecture. Thank you guys for watching, and don't forget to subscribe and follow us on our social media platforms. And I will see you guys in the next video.